Hello, my name is Kunal Jaju. I'm the clinical director for the Division of Gastroenterology at Brigham and Women's Hospital, and I've been given the task to summarize the GI section and give you some GI take-home messages and some clinical pearls. So in terms of GI take-home messages, you just received a whopping dose of gastroenterology data, and you're probably wondering to yourself, how will you metabolize all this? Will you use some of the techniques that we used in medical school, using acronyms or writing out pathways? Will you use some clinical vignettes to try to remember everything that you were just told in our section? I think for me, the easiest way would be to use a systems-based approach, and that's how I will summarize the GI take-home messages today. And thankfully, some of my colleagues already gave you some clinical vignettes to use and some of the questions and answers I think, that really helps you take home and really hone in on the salient points. So we'll start at the top regarding the esophagus, and you learned that GERD is quite common. Gastroesophageal reflux disease is quite common. The treatment of GERD includes lifestyle changes, and the mainstay, of course, is acid suppression. That may be with a use of H2 receptor antagonist or with a proton pump inhibitor. And sometimes surgery may be required for fundoplication or laparoscopic anti-reflux surgery. Upper endoscopy and pH testing can be utilized to confirm the diagnosis of GERD and are generally reserved for those situations where there are alarm symptoms or new symptoms that the patient describes, or if a empiric course of acid suppression has failed, thereby there's been treatment failure. As many of your patients have read about and have brought to your attention, and obviously you've read about it as well, the long-term effects of proton pump inhibitors need further investigation. We learned that Barrett's esophagus is a direct result of gastroesophageal reflux disease and is a precursor to adenocarcinoma. The progression rate of Barrett's to adenocarcinoma is thankfully much, much lower than was initially thought. But for reasons that are unclear to me, patients still refer to the higher rates that they see when they Google this. Screening is indicated when multiple risk factors are present in a patient, and surveillance is indicated given that treatment for dysplasia, precancerous changes in Barrett's, is quite effective. We learned that eosinophilic esophagitis is an increasingly recognized allergic disorder, most commonly presenting as dysphagia, often food impaction. Proton pump inhibitor therapy can be the initial treatment algorithm, and then we would proceed to an elimination diet, coordination with our allergy colleagues for food allergy testing, and then swallowed steroids can be a mainstay for therapy in eosinophilic esophagitis. We learned about motility disorders and how they can be quite difficult to diagnose. Of course, if a patient is presenting to us with dysphagia and difficulty swallowing, we must first rule out any structural causes before we consider motility or dysmotility as the cause. High-resolution manometry can distinguish amongst the types of dysmotility disorders, and they can help to direct therapy based on the type of disorder that's found on the manometry. We learned about peptic diseases, peptic ulcer disease being most commonly caused by nonsteroidal anti-inflammatory drugs or H. pylori, or both in some patients, and these can be synergistic, and we often have to rule out use of both in patients who have recalcitrant or recurrent ulcers. Please remember that nonsteroidal anti-inflammatory drugs are quite underreported in the patient history. Patients often consider only prescription medications when they're asked what medications they take, and they don't think of Advil, Motrin, ibuprofen as being significant medications often when they're first asked. We know that proton pump inhibitors have a more rapid response in healing of peptic ulcers than do H2 receptor antagonists. We also learned that a more restrictive transfusion regimen can be beneficial for patients with bleeding peptic ulcer disease. We also know that patients who are on aspirin for secondary prevention of cardiovascular diseases should be restarted within 1 week of diagnosis of a peptic ulcer. And further delay can put them at higher risk for cardiovascular complications if their aspirin is held. The newest H. pylori guidelines favor a test and treat strategy for non-ulcer dyspepsia, idiopathic thrombocytopenia purpura, iron deficiency anemia, and prior to long-term NSAID use in those patients with rheumatologic disorders or other disorders that require them to be on long-term non-steroidal anti-inflammatory drugs. A test and treat strategy is preferred. The treatment algorithm for H. pylori hinges upon the patient's prior macrolide exposures, any history of penicillin allergy, and there is still thought towards local resistance patterns, but we must remember that macrolide resistance is quite high across the country. There are bismuth, clarithromycin, levofloxacin-based regimens, which you learned about, and there are also sequential regimens that can be used. And each have their own advantages and disadvantages that you learned about from Dr. Parencevich. Moving on to inflammatory bowel diseases, we generally categorize them under ulcerative colitis and Crohn's, and we use strict clinical parameters to define the severity of disease. We learned from Dr. Friedman that the goals of therapy include inducing remission, both clinical remission and biologic remission, that we favor steroid-free therapies, and a goal includes avoiding surgery and hospitalization with outpatient infusion and other therapies. There truly has been a paradigm shift over the years and really has been established now for quite some years, the shift, and such that step-up therapy has been replaced by top-down therapy, meaning that we should be treating early in moderate to severe disease using immunomodulator therapies and potentially biologic monoclonal antibodies. We do still have to be aware of the long-term complications of both the diseases of inflammatory bowel disease and the treatments, including osteoporosis, cancer risks, which is highest in those who have pancolitis or universal colitis, and that there's an ongoing need for surveillance in these patients. Shifting gears a bit to the liver, we learned from Dr. Viveros about hepatitis B and hepatitis C screening and surveillance strategies. Hepatitis B is truly a risk-based screening strategy, and I won't go through each of the details. She showed you a very nice slide regarding who is considered at higher risk. You can consider obtaining a serologic hepatitis B surface antigen and surface antibody as your first step, or you could consider obtaining just the core antibody as a first step and then triaging whether you need to obtain the surface antigen and antibody based on positivity of that test. We learned about a new 2-dose regimen with a 1-month interval that has a higher seroconversion rate than the prior hepatitis B vaccine. For hepatitis C, we've actually shifted from a risk-based screening to universal screening, such that hepatitis C antibodies should be obtained in all patients above the age of 18, not just the previous guidelines of baby boomers. We know that there are direct-acting antivirals which have a sustained virologic response using an oral medication regimen. And there also has been a shift because of the efficacy of these oral regimens, there has been a shift toward treating acute hepatitis C when you can confirm that it is an acute infection. We also want to keep in mind that the guidelines for screening for hepatocellular carcinoma have shifted a bit and actually come back to previous guidelines, such that serum alpha-fetoprotein and abdominal ultrasound should be obtained every 6 months in those who are high risk for hepatocellular carcinoma, including those with active hepatitis B and those with cirrhosis and hep C, or cirrhosis and non-alcoholic fatty liver disease. In those with cirrhosis, decompensation, clinical decompensation occurs in the vast majority of these patients. The sequence of clinical parameters that generally occur in decompensation uh, in general is that patients will present first with ascites, then potentially jaundice, photosystemic encephalopathy, and variceal bleeding. New ascites in a patient with cirrhosis does warrant paracentesis in order to determine the exact cause. And in this paracentesis specimen, fluid specimen, we would be calculating the SAG, or the serum albumin ascites gradient. And we know that when that SAG is greater than 1.1, it is highly likely to, the ascites is highly likely to be due to portal hypertension. The treatment of ascites includes sodium restriction and diuretics, including furosemide and spironolactone, given together as a single daily dose. In those who have recalcitrant or worsening ascites, we have to think about large volume paracentesis and sometimes even a portosystemic shunt via TIPS with radiology. In those with cirrhosis, we have to be aware and mindful of hepatorenal syndrome, defined as renal impairment that does not respond to holding diuretics or volume expansion. We know that there are two types of hepatorenal syndrome. Type 1 is the acute type, which is generally precipitated by either spontaneous bacterial peritonitis, alcoholic hepatitis, or occasionally surgery that was done for another reason. Type 2 hepatorenal syndrome is a more chronic phenomenon in those who have refractory ascites and develop a creatinine of greater than 1.5. Hepatorenal syndrome continues to portend a relatively poor prognosis. Treatment options include a combination of albumin, octreotide, and midodrine, and patients with refractory ascites may require TIPS, as I mentioned earlier. In those with cirrhosis, we also have to screen for varices. If varices are seen on upper endoscopy, then the choice must be made for either non-selective beta blocker if the patient's heart rate can tolerate it, or endoscopic band ligation if there are esophageal varices. Acute variceal hemorrhage most often needs to be managed in the intensive care unit, and there should be prompt consideration for upfront endoscopy with banding. And also, if possible, and if there's expertise in your local unit, there should be consideration of early TIPS, early radiographic portosystemic shunt for those who have a Child-Pugh Turco score in the B to C range. In those who have gastric variceal hemorrhage as opposed to esophageal variceal hemorrhage, they may require interventional radiology for BRTO, or they may require endoscopic coiling and or glue placement of to thrombose those varices. The mainstay of treatment for cirrhotics, of course, is transplant. These patients are triaged by their MELD score. The MELD score is highly predictive of the patient's 3-month mortality. As I mentioned, it's used to transplant and prioritize, it's used to triage and prioritize for transplantation. And in general, once the MELD score is greater than 15, patients are considered for transplant. They, in general, require both a MELD of greater than 15 and some form of clinical decompensation, as we previously defined. Allocation of these organs is regional, and as you may know, there is great variability in availability of organs depending on which region you practice in. Therefore, living donor liver transplant has been utilized due to the scarcity of cadaveric organs. And Dr. Rutherford spoke with you about some of the exclusions for both orthotopic liver transplant and living donor liver transplant. Shifting to the pancreas, we learned about acute pancreatitis. We learned that it is most commonly due to gallstones or alcohol. In order to define acute pancreatitis, we look for at least two of the following three criteria: typical pain, being epigastric pain radiating to the back, an amylase or lipase in the serum greater than 3 times normal, and typical imaging with stranding around the pancreas. The severity of acute pancreatitis is graded based on the presence of local complications and the degree of organ failure. The treatment is early, aggressive fluid hydration, and we prefer to use oral feeding as opposed to enteral feeding, preferably avoiding TPN if possible. And studies show that a nasogastric tube may be equivalent to a nasojejunal tube in terms of efficacy. Of course, this can be limited if the patient has a small bowel ileus in the area around the pancreas, limiting the flow of the nasogastric tube feeding. In those with acute pancreatitis, ERCP is only indicated in patients with concomitant cholangitis or evidence of ongoing biliary obstruction by a gallstone. Antibiotics should only be utilized in those patients who also have cholangitis, but should not be used for prophylaxis in patients with severe acute pancreatitis. Ideally, cholecystectomy in those with biliary pancreatitis should be performed in the same hospitalization, as long as there is no necrosis associated with the acute pancreatitis. We learned about the types and causes for chronic pancreatitis, whether they be toxic metabolic, idiopathic, genetic, autoimmune, recurrent, or obstructive. Exocrine pancreatic insufficiency is treated with pancreolipase, and some dosing regimens were provided. Ideally, our goal should be towards an opioid-sparing pain regimen, and steroids remain the first-line treatment for autoimmune pancreatitis. From Dr. Smith, we learned about the evaluation and management of diarrhea. Acute diarrhea is most commonly viral, less commonly bacterial. The most common viruses that can cause acute diarrhea include norovirus and rotaviruses. And I'd be remiss to not include a mention about COVID-19 and its effect on the GI tract. Studies from our institute that were spearheaded from our institution, including a multi-center study, showed that up to a third of hospitalized patients with COVID-19 reported diarrhea. The majority of these patients also had fever or respiratory symptoms, but it should be noted that a minority of these patients had diarrhea as their only presenting complaint. When we think of bacterial diarrheal infections, salmonella was discussed and the need to avoid antibiotics if salmonella is suspected or confirmed. Campylobacter, C. diff was discussed, and as well as enterohemorrhagic E. coli, another cause of acute diarrhea that we would want to avoid antibiotics for. Ova and parasites should be considered when patients have more than 14 days of symptoms, whether they have travel or exposure. Dr. Smith discussed the many causes of chronic diarrhea, including inflammatory, specific medications, exocrine pancreas insufficiency, when to consider celiac disease as a possible cause, and when to consider microscopic colitis as a possible cause. Thank you for reviewing the take-home messages and clinical pearls with me for gastroenterology. Thank you for your time.